Hey guys, it's Ahmed here, and I'm here to give you my lecture on the basics of ECGs. Basically, what I want to cover is how do you set up and interpret and present an ECG, and at the end there's some three examples that I think you guys should go through. Right, so overview. So ECGs are a basic investigation. Nearly all patients will have them. So if you're on the wards, go through their notes and have a look. You'll most likely find one, and it's good to practice. The more you practice, the more easy it will become, and by the time you're at your off skis, you'll go through it real quick. Set up. Okay, so this is actually really, really important. I say this because I had a station just like this in the exams. So there was a patient, or it wasn't a patient, there was a dummy, one of those CPR dummies on the bed, and there was an ECG machine next to him, and an invigilator. So you had to go in and set up the ECG with all the leads in the correct places, state where you were going to put them if they weren't sticking. After that, you get handed a piece of paper with an ECG readout, and you are required to present and interpret and answer the questions from that. So it's very important that you know how to do this. So it's right arm, left leg, right leg. The red and the color coordinated red, yellow, green, black. You also have chest leads, not color coordinated, but they are labeled 1 to 6. 1 and 2 are fourth intercostal space, but left and right sternal edges. Fourth is at the apex beat, which is fifth intercostal space, mid-clavicular line. Chest lead 3 is in between 2 and 4, halfway. 6 is at the mid-axillary line, fifth intercostal space. Chest lead 5 is between 4 and 6, exactly halfway on the same line. This is Einthoven's triangle. It shows you the relationship between all the leads, including unipolar ones, which are AVF, AVL, and AVR. Important to have this in mind. Now this is the ECG in full. So presenting this, you want to begin with patient info. So who is this patient? How old are they? What's their date of birth? What's their hospital number? When was this taken? How fast is this running? Usually 25 millimeters per second. And then you can move on to assessing rate, rhythm, axis, waveform, and diagnosis. Axis is semi-important, but a lot of the times people do miss it out. I think I missed it out in my exam, and I'm still here, so it's all good, guys. It's all good. So this little diagram explains or visualizes how the leads are in relationship to the actual structural anatomy of the heart. This is super important because then you can localize any pathology. For example, if there's ischemic changes, you can say which part of the heart is it coming from, and therefore which artery is the problem. So 2-3 AVF, inferior. V1, 2, 3, so a bit of 4, anterior septal, mostly left anterior descending artery. 5, 6, lead 1 and AVL can be septal or anterior septal. So it's usually the left ventricle or the left circumflex artery. So it's really important to figure out. Another thing to note, over here, V7, V8, and V9, I never mentioned them in the setup because it's unconventional to have those. You only usually have them if you're looking for a posterior MI. I would recommend looking up the other signs for a posterior MI. It's out of the scope for this lecture, but it's good to know. So beginning, rate and rhythm. Right. I usually check rhythm first, but sometimes it's okay to see rhythm. Rate. Basically, when you look at it, and if it's obviously not in sinus rhythm, it's very difficult to judge the rate because the rate depends on it being normal sinus rhythm. Well, this method does at least. So 300 divided by the number of big squares. If it's not in sinus rhythm, you got to do it the long way, guys, and nobody likes the long way. So what do I mean by a big square? A big square is follow this. So I'm clicking from here to here. So this is how I assess rhythm. Look at the distance between R waves. So just actually a quick recap on ECG, P wave, QRS complex, T wave. You should remember that from second year. So the distance between R waves, they should be equal. Sometimes they can be all over the place. Sometimes they can be all over the place, but there's a set pattern to it. So for those ones, if there's a set pattern, you say regularly irregular rhythm. Sounds weird, just how you got to do it. Irregularly irregular rhythms, there's absolutely no pattern. It's totally bonkers. They're all over the place. So if you're thinking irregularly irregular, you've already got a very solid, like, something it's pointing towards. It's usually AF. Or that means atrial fibrillation. Also, this is a good thing to note here. So a big square, usually 0.2 of a second. Sorry, that many squares. So 1 second is that 1, 2, 3, 4, 5 big squares. A small square in itself is 0.04 seconds. All right, describing the wave. So let me zoom in on this. So here, so this is your P wave, QRS complex, and T wave. What do they correspond to? So P wave is atrial depolarization. QRS means, please go away, come on. So QRS means ventricular depolarization, and T wave means ventricular repolarization. So a P wave, so let's go back so we can see all the intervals. So you want to see if there are P waves. Are they present? After each P wave, are you getting a QRS? Are your QRS complexes adequate size? Are they narrow or are they broad? This is super important because certain arrhythmias are only present in broad complex or narrow complex QRS complexes. You know, I say complexes a lot. Next, after you've assessed P and QRS, look at the T wave. Is there any inversions? Are they a funny shape? Describe the shape. Look at the intervals, PR interval. So let's zoom in on this again. So a PR interval, counterintuitively, is actually the start of a P wave to the start of a Q wave, not from here to here, as many people think. You want to look for P wave elongation, sorry, PR interval elongation, usually in heart block. That will be in the next lecture on arrhythmia. Don't worry, it will be covered. You want to also see QT interval. Very important depending on what medications the patient's on. For example, antipsychotics can cause QT elongation. Other medications can cause similar things. Why is that important? Because with QT elongation, the patient is much more susceptible to something called torsade de pointes. My French accent's horrible. It's basically a variable ventricular tachycardia, and it's very dangerous. Well, it can be very dangerous. So be on the lookout for that. So now you've described the wave. You could also check for ischemic changes. For example, ST segment elevation, ST segment depression. Look for T wave inversion. So basically it's going the wrong way. So those are ischemic changes. Another one would be probably left ventricular hypertrophy. So you get really super tall and super deep S waves. And yeah, so describe what you see. Axis. So a lot of people skip this out. I have a very simple, quick way of figuring it out. Other people use Einthoven's triangle, try to figure out the isoelectric lead and sort of work it out from there. What I do is looking at lead 1 and lead AVF. I see which ones are positive, which ones are negative, and from there I can work out if there's left axis deviation or right axis deviation. So if lead 1 is positive and lead AVF is negative, could be a left axis deviation. If lead 1 is negative and lead AVF is positive, could be right axis. So the mnemonic I usually used to use for this is right reaching, left leaving. So let's go up to the initial one here. So looking at the R wave on lead 1, you can see it's positive. AVF also positive, so it's normal. If AVF was negative, it looks like the R waves are pointing away from each other. So I say leaving, so left leaving, left axis. Right axis would be if one's R wave was pointing downwards, so they're both, so it's negative, so they look like they're pointing towards each other or reaching for each other. That's right axis deviation. So this is just a modified Einthoven's triangle showing you the actual degrees of deviation. It's one way to work it out, so you find the most like neither positive nor negative, or isoelectric lead, and you can say the electroactivity is going opposite that direction, so it must be going the other way. It's a more complicated way of doing it. In an exam, I would get too flustered and I wouldn't remember it, so I memorized the other way of doing it. Now, so here's some good examples for you guys to go through. I can go through it myself with you guys now, but if you want to give it a look, I would recommend giving it a look. So, obviously, patient info, technical info. Let's say that's assumed that's done. So rate, personally I would go at rhythm first here. So there's roughly 1, 2, 3, 4, about a bit more than 4. I would say this is roughly normal sinus rhythm. Because it's around 4 squares in my head, 304, about 75, exactly, 75 beats per minute. So we've got rate and rhythm straight off the bat. At this point, I would usually describe any obvious abnormality. I can't actually see any, but then again, I'm only fifth year. So P waves, they're present. Each P wave has a QRS after it. PR interval, adequate. We can probably zoom in. No, it won't let me. So it's about 4-ish, 3-4-ish squares. It looks at, basically what I'm getting at, it doesn't look grossly large. The QRS doesn't look dagger-like, it doesn't look broad, so I would say it's a good QRS complex. T waves, present, not hyperacute, not flattened, not inverted. Looking at ST segments, fine, no elevation, no depression overall. There's no obvious ischemic changes. Axis, AVF is positive, 1 is positive, normal axis. So in summary, this is a normal ECG, full lead ECG, 75 beats per minute. Now, just look at this one. You can obviously, like, straight off the bat, you can tell there's something not right here. 3 is very small. I would call that isoelectric maybe. Also look, you can instantly tell this is not in sinus rhythm. They're all over the place. I can't detect a pattern. I would call it irregularly irregular. So now that you already know it's irregularly irregular, you can probably think, oh, maybe AF. Look for P waves. There are no P waves. So P waves, irregularly irregular, thinking AF. You can also go on and say QRS, not too broad, it's fine. T waves, cannot actually picture any T waves. There might be some, you can convince yourself. And, oh yeah, almost forgot. Deviation, right. So this actually looks almost isoelectric. So we're bordering on left axis, but I would say normal. So yeah, in summary, this is atrial fibrillation. Here we go, another one. So instantly look at it. I would say roughly, yeah, there's no rhythm strip, so it's a bit difficult to tell about rhythm. Rate, 1, 2, 3, 4, again, about 75. P waves are, now, here, straight up, I'm gonna point out the elephant in the room. There's ST segment elevation in leads 2, 3, and AVF. You can probably convince yourself that V2 has ST segment depression, but don't worry about it. There's no T wave inversion, maybe AVL, but suspect. So yeah, there's widespread ischemic changes on this ECG. Then I would go on P waves, they're present. No, there's no PR elongation. Q waves, QRS is not broad, and widespread ischemic changes. So this is indicative of an inferior STEMI or ST segment elevated myocardial infarction. And that's the basics of ECGs. If you have any more questions, do ask me. Thanks, guys.